All right, good morning and thank you for keeping it Citizen Television. Thank you for waking up with us and for joining us for this particular segment, Health and Lifestyle. It is Wednesday and like I always say, we do not take your time and company for granted. We hope wherever you're watching us from, you're learning and you're becoming better, taking care of yourself and even understanding the different conditions that we're all battling with outside there. So this month, there's a lot that has been going on and we know that March is usually a time when the whole world actually escalates awareness around endometriosis, and that is what we want to talk about. When you talk about endometriosis, we remember the story of the popular radio presenter and reggae DJ Mary Njambi Koikai. She's actually one of the people that brought this problem really to the forefront and help us understand how it feels to really wear that particular shoe. She dedicated her life to passionately talk about endometriosis, her lived experience, and unfortunately she died last year but left a legacy in terms of, you know, how this conversation was picked up. But one thing you do not know is that there are many Njambis out there who are suffering silently in pain when it comes to this particular gynecological condition. And I am glad that in studio this morning I have an expert and also somebody who is an endometriosis warrior who's going to be sharing with us how personal she has really lived this experience and what has worked for her. Now she's saying she's living near, if not a normal life, yeah, courtesy of what has been done. I'm talking about a panel of two amazing ladies. I'll begin from my far right. I'm hosting this morning Dr. Hiba Ahmed Tajiud. She's from the Kenya Obstetrical and Gynecological Society. She's an obstetrician and a gynecologist. Thank you so much for creating time for us.
Thank you.
And of course, you're also having this morning Haveen Bansal, the endo warrior that I was telling you about. It's so good that you created time to openly come and talk to us about your own personal experience about this. But probably as, let me begin with you, Daktari, as we mark this, you know, this month around awareness around endometriosis, probably it would be a good thing to also capture your mind on what is your key concern. What is the main issue that you feel should be really focused on this particular month of March as we mark this awareness?
Thank you so much for the invitation. It's really an honor to be here. And at the same time, it's a really good thing for Citizen TV also to pick up this. It's part of the awareness program that we've been working on in regards to endometriosis. So one of our biggest concerns right now is awareness. We just want everyone. Let's talk about clinicians, let's talk about the community, let's talk about students. Everyone should know what endometriosis is, so that if they find a relative or a sister or themselves they're experiencing it, they would know the path to follow and where to seek help. Yeah.
All right. And for you, Haveen, what excites you about this month of awareness? I know probably I'm just assuming during the time that you got your own diagnosis, this was not a very big conversation, you know, if you compare back and probably you'll take us through your story in just a bit, but what excites you about what's happening, you know, these days about the conversation around endometriosis?
I will say, starting from, considering from when I got diagnosed, the conversation, there's a lot more conversation going on around it, in between patients, in between friend circles and social groups, in between clinicians as well. It's not as much as we would like it to be at the moment, but still it is more than it was when I got diagnosed in 2014. So it's good, and you know, that's why when I joined the Endo Sisters, I decided to, you know, give a part of my time to help create this awareness, because if you don't know, you will not be able to deal with it. So that's the main goal.
That's why we're here. Yeah. And we hope it is a conversation that should go on beyond March.
Yeah. Yes.
Beyond the month of March. 11 years, that's 11 years ago. That's when your story with Endo began. We'll get into the depth of that shortly. But Dr. let's begin from the very basic. When we are talking about endometriosis, what exactly are we looking at and how different or similar is it to the menstrual pain that people probably are more present with?
Yes. So before we go into the pain, maybe we try and understand what is endometriosis first, okay? So, you know, the way we've been created, our body is divided into parts. The skin is very different from the cells of your eyes, very different from the cells of your lungs, very different from the cells of your womb. So inside your womb, there are some special cells called endometrium. That's where the name endometriosis comes from. So when this endometrium is somewhere else in the body, wherever it is, that is when it's called endometriosis. Now remember...
So it could appear anywhere else?
Anywhere else, even in your skin, your lungs. It can even appear inside your abdomen, now from the inside, okay? And that is now where problems start. Because as a lady, and remember, endometriosis starts when you start your period. It cannot happen before your periods. So when you start as a lady, a girl child, when she's exposed to estrogen, you see for a boy child, they have testosterone. For a girl child, they have estrogen. So remember, estrogen makes those cells grow. So in the uterus, in the womb, they are growing, bleeding. That's period. So the girl starts to have period. So what happens to these cells when they're in other parts of the body? They still also grow and bleed. And that now causes pain in other parts of the body. Okay. So you'll end up seeing a girl is having a chest pain every time she gets her period. Or she'll have tummy pain when she gets her period. Because those cells that are not supposed to be there are responding to her periods. So every time she gets periods, she's getting those kinds of period-like things growing in other parts of her body. And that is, it's something foreign. It's like you have a cut here. What does your body do? It reacts. So everywhere these endometrioses are, the body reacts around it. So it starts to hurt, it starts to cause pain, and it starts to cause something called irritation or inflammation. And that is why the patient comes with pain.
All right.
You get me?
I've never actually met somebody who explained it so
Yes,
simply.
it's basically as simple as that.
Feelings in the parts where this endometriosis is.
Yes. So you can even get it in your umbilicus. And then it swells when you get your period.
Even lungs?
And even lungs. And you start coughing blood. And where does our patient goes? They goes to a lung doctor. Because there's no awareness going around that if you have something related to your periods, or happening around the time, not necessarily, but just generally. So when we speak about the pain, it's very different from the normal, we don't say normal pain. Menses are not supposed to be painful.
First of all.
Yes, that's the word. It's not supposed to be painful. But sometimes you reach a point where the pain is putting you down. The girl child stops to go to school. Her scores start to drop. She's not focused. The partner, if she has a partner, she's not so engaged because she's having pain even during sex. She's having pain when she's passing stool because it's around the bowel. She's having pain when she's passing urine because it's around the urine area. She's having pain around the chest. So
it's overwhelming pain that cannot allow you to do anything else.
Yes, it's actually scored one of the most painful conditions, even sometimes more painful than cancer. And you expect that person to survive and go on with their life. So it's not just about the aspect of, like, medical aspect. It's physical, it's mental, it's social. You see, someone loses touch with the reality because of that pain. And it's not just a pain that happens during the day of periods. It happens before, the week before.
No wonder the World Health Organization calls it life-changing pain.
It is life-changing.
It turns your life around. If you're a student, if you're working, if you're a wife, it can even interfere with your relationship.
Actually, your life becomes upside down. You're not the same person. You will notice, the people around you will notice.
So now that we've talked about WHO, just run us through how big of a problem is this? You know, we only hear about Njambi, and at least today we have Havin, and we have others who have also come out there to create awareness around this. But one thing about endometriosis is that it is still a very silent, complication that many women out there have not even come out to say. So how big of a problem are we looking at?
You've mentioned a very important point. It's a silent. And why is it silent? Endometriosis prior to 2000 was not considered an African issue. Research was mainly done among Europeans. And what happened, if you notice in research and data, it has not started until 2000. So prior to that, even us as clinicians, we wouldn't think of it. And then the other factor is, as an African woman, I don't know, would I say it's cultural or norm, you're told to tolerate period pain because that's what labor is like. You'll get used to it.
That's what you're told.
Yeah. So those two combined together really created a deadly silence, where you'll find them existing on painkillers to the point of even addiction because they don't have any other resort. They can't go to a doctor because if they go to a doctor, they might be dismissed at that time. From 2000 onwards, people have started to notice, okay, they've started to see people come with endometriosis. They've gone in and seen those endometriosis. Research has been collected, and WHO, now we are saying about 5 to 10% of women, that is 5 to 10 in every 100 women, that is like 1 to 2 in every 20 ladies you know, can have endometriosis.
So it's that close.
It's that close to home.
I think the statistic we normally quote is 1 in 10.
1 in 10. It is that close. And you are one of those numbers.
I'm 1 in 10.
So you really relate. Stage 3 deep infiltrating endometriosis. That is what you were diagnosed with.
Yes.
Having take us to 2014.
Okay. Yeah. So 2014, so the symptoms I had were presenting as gastric symptoms. Doctor has already explained that it can be in other parts of your body. So because it was presenting as a gastric issue, I never went to a gynecologist, right? I went to a gastric doctor. But even before I got to the gastric doctor, the symptoms that I had were in the stomach here, and they would be cyclical, but not exactly monthly, like coordinating like with the menses. They would be 5 weeks, 7 weeks, and it would just, my system would just shut down, and I would have to throw up everything that is in my body up until I have nothing left, go to ER, get pethidine, get really strong painkillers to stop the spasms. And I went through that for about 1.5 years. So before that, there was always pain, like I said, here. But, and, you know, like we were told, it's just normal. Periods hurt, you know. You have your 2-3 days, feel pain, and then you get on with your life. So then now, when 2013, when these symptoms started, we started to get confused because what is the issue, right? And finally, when we did a CT scan, is when we found a blockage in the small intestine. So at that time, my doctor said, we need to go in laparoscopically, and just to see what this blockage is. Because
so all this time, it's still being handled as a gastric complication, You've not gone the gynecological path yet.
Exactly.
All right.
So he said, let's do a CT scan, and then we found the blockage, and they said, okay, let's do a laparoscopy, because from outside now, I cannot tell what's going on inside. So we go in, do an hour, take a biopsy, just see how things are, what is wrong. And, he went in there and found a really big shock, because the endometriosis I have, which is deep infiltrating endometriosis, is called that because it infiltrates your other organs. So some endometriosis might just grow around them, but this one infiltrates. So that's what it had done. It had infiltrated the small intestine and blocked it. So your small intestine, moves around every now and then. And what would happen when it would reach that spot where the blockage was, it would completely close up, and that's when I would have the throwing up symptoms. So he went and found that out, and then he had to call a gynecologist to come in, because this is now not his level of expertise. So he called him, and what was supposed to be a 1-hour laparoscopy became a 5-hour surgery. So they excised the endometriosis. The organs were all joined together. So small intestine, big intestine, uterus, ovaries, tubes, appendix, everything was like this.
Merged,
So they had to separate them, remove the tissue, resection part of the small intestine, and then that was the surgery. So
all this is happening in a duration of how long? So 2014 is when you begin to feel something is not
2013
okay?
is when I began to feel, and then August 2014 is when I had the surgery, first one.
All right.
Yeah.
All right. She's mentioned quite a bit of symptoms and telltale signs. Maybe it would be a good point to also take us through it. How does it present? Because for her, it was the gastric issues she was having. So other women who may not necessarily go through what she went through, what is it that they can begin to feel or see that can tell them early? Because I understand with the endometriosis, the earlier the better.
The better.
So what is it that you can,
And I think also she's gone through a lot, yes, but usually endometriosis, the average time to actually get it is about 7 to 10 years. So imagine you're just going around. So let's go back to the symptoms. So we said pain. Why does pain happen? Because, for example, you have endometriosis on the inside of your abdomen. So it's growing, it's causing you pain on this side. It is causing you such excruciating pain and irritation. Remember that irritation part, which is what causes the tissues to stick together, because it becomes sticky when it's irritated. So now you have the ovary sticking to the uterus, the bladder sticking to the uterus, you have the bowel sticking to the uterus, because it's creating an irritation. So if the bowel, for example, in her case, is involved, it's stuck there, or the endometriosis is on top of it, you get now symptoms related to the bowel, which is diarrhea, pain when passing stool, vomiting, gastric, as we say, gastritis.
And you end up treating those.
Yes, and you're treating those
are
things.
the issues.
Another thing, it could be next to the bladder, and you get pain when passing urine. The doctor starts to think, oh, it could be a urine infection. But now you come back every month. You cannot get urine infection every month, right? So that should be something that is making you think, okay, maybe I'm dealing with something else. It could be in your lungs, and then you get pain, as we said, every month or even daily. But your pain is also very excruciating. So once you have that painful, that is affecting the quality of your life as a woman, endometriosis should be one of the things that should be at the back or at the front of our head even. Yeah. So depending on where it is a presentation. But the most common one is this around this area, which is the pelvis, what we call the pelvis, because it's the closest to the uterus. So it's the closest place for the endometriosis to travel. So you tend to see them mostly have that pain just before, around, or even throughout the month. You get me? Also, it's pain that comes not just around the time of menstruation. Not around the time of menstruation. It could come any other time. It could come any other time. For any other reason. It could be cyclical or not cyclical. What does cyclical mean? Like cycle, period. It comes every time, just before your period, a week to your period. And it could be throughout the whole month. Why? Because of the irritation. Remember that irritation we are talking about. The irritation doesn't respond to hormones. It's there. Your skin is cut, it will be cut. It won't go away. So that irritation will still be there the whole time, which causes that pain. All right. Yeah. She was diagnosed with what she has explained to us in simple terms, infiltrating endometriosis that affects the organs. Is that the only one? Talk to us about the types. Yes. So what we have with endometriosis was that specific one. So are there others? Yeah. So we usually stage it. Just like when you say stage 1, stage 2, stage 3, stage 4. Stage 1 is usually a mild one where you just have small deposits. 2 is a bit more in. 3 is now when it goes into the, for example, the gut or the bladder or those other organs, it goes deeper. And 4 is more extensive. So from 1 to 4, 4 is the most severe, 3 is severe, 2 is moderate, and 1 is the mild. But remember, the extent of your endometriosis does not correlate with your symptoms. Someone can have so much endometriosis when you go in and see, but they'll tell you, I don't have pain. Someone can have very little deposits, but they still have pain that is not making sense to them. Yes. So that's also creating a bit of a challenge, because another very common presentation is infertility. Remember, we said things stick together. So the way your womb is created with its tubes, it's supposed to be clean in a certain position. So when the ovary sticks to it, when the gut sticks to it, you can imagine how it can disrupt the fertility issue. So you'll see someone doesn't have pain, and you want to find out why they are not able to conceive. So you go in and you find out, okay, this is endometriosis. So you'll find that that is another silent presentation of endometriosis. So pain is not the only symptom. Yes, it's so extreme. It's like we are still discovering new ways of it showing up. Presenting. Yeah. All right. I mean, if you go back to what you were going through, you underwent surgery twice. Yes. Yeah. It recurred, and then you had to undergo another surgery. Yeah. I want you to take me through what happened between the first surgery and the second, and these surgeries. What is the nature of surgery, what was done, and what were the outcomes? I know this will come part of the treatment options that are there for endometriosis, but just run me through what was done, what sort of procedure was done, and why, and what were the outcomes after that?
So after the first surgery, both doctors, so because now I had a gastroenterologist as well as a gynecologist involved, surgeons, right? Both of them were very clear to me that this can recur. we have done this, you are okay for now, but this can recur. Number 2, when you go in surgically, you will always leave in scar tissue. So that will also affect you. I think initially, just because of, all the pain that I was having before, after the first surgery was gone. Even with the regular cycle, I was not feeling pain, and I was like, wow, I'm healed, I'm okay, right? And even though they had told me, and I understood that, it can happen again, I still just thought, okay, I'm all right
for now.
Yeah, I'm okay. So post-surgery, you go through some injections, some hormonal injections, which either you take 1 dose of each. One makes your body think you're pregnant, and the other one makes your body think you're in menopause. So both of them, what they do is they suppress the endometrium from growing.
Oh, so they inject you a drug that makes your body
think it's pregnant or in menopause.
It actually
and I tell you,
helps.
the menopause one is not fun.
So you're even given menopausal doses?
Yeah.
Okay.
So the point is, because what they're trying to get is suppress the endometrium from growing, right? Because when it's growing, when the estrogen is kicking in every month, it's growing, that is what is causing the issue. So they're suppressing it. So after my 2 doses after the first surgery, I was okay. And, everything was good for about 4.5 years. So I never even thought about it again. And then 4.5 years later, again, I got the symptoms. I was telling you about the gastric symptoms. So because you know what it was before, and you're experiencing the exact same symptoms, you're more concerned. So I actually, in 2014, before I got the diagnosis, I had those symptoms, those episodes maybe 7, 8, 9 times. And so this was the first time I had it, the second time, and then the third time I had it, my doctor said, okay, I don't want to take a chance anymore. Let's go in. So I said, yes, please, definitely, because I do not want it to get to the stage where it was before. And unfortunately, when he went in, I was diagnosed with stage 3 at the first surgery, and this was stage 4. It was even worse. So the surgery involves, like I said before, they first separate the organs. One doctor deals with the intestine. So the first surgery, they cut about 4 centimeters of my small intestine, and second time they cut a foot. So he has to cut out a whole foot of the bad place and then resection and join the ones, so it's working again. On the gynecological side, they remove the tissue, the endometrium, they clean it up. I actually watched my surgery video, so I know what
so after. You make it sound so easy. I'm just here thinking, okay.
It's not easy, but I watched it because I wanted to understand what it is, done, And, they clean it out, they separate the organs. Like the first time they had to cut out the appendix as well. Second time, so now they're just, moving the organs apart, going through the bits and places to try and remove as much tissue as they can, because anything that's left behind is going to grow. So we did that, and then again went through the injections, the pseudo pregnancy and the pseudo menopause, and actually those worked really well for me at that point. And I asked my doctor, can I just continue on these? But unfortunately, what you have to understand is, because these drugs are so strong, they're really not good for your body. So they affect your bones, they affect so many things. So 2 doses is the maximum you get. And then after that, I was put on a coil called Mirena, which is an IUD, which also releases hormones and gives the same effect as the injections.
All right. So right now, it's hormonal therapy, hormonal
exactly.
management. Yeah?
So the Mirena coil is something that it lasts for 5 years. So I've had mine for 4 now, and next year I will change it. And it just does the same job that the injections do. So they suppress the endometrium, so I don't really get regular menses. Ever since the second surgery. It's just, bits and pieces here and there, what gets released, but I don't have them. So because of that, the endometriosis is not growing, and I'm okay. Yeah.
So by okay, what is like your general quality of life right now compared to 2013?
150 times better.
All right.
That's
definitely.
Nice.
All right. That's good.
Yeah. And I am very, very lucky. I had great doctors.
All right.
I had great support, and even post the second surgery, I was in a bit of a mental slump, because you you know, it's happened again. So now you wonder, how many times is this going to happen? What's going to happen? And that's when my gynecologist referred me to a support group. And through the support group as well, you know, I've learned from other endo warriors, from our board, from, you know, all the different things you're exposed to being part of a support group, which has helped. And I think the mental health, being positive in your brain helps your body to heal as well.
All right, we'll get to that because I want to understand what endometriosis has taught you and how it has changed your life. But her story has really like elicited a lot of issues, from just diagnosis to even treatment and the options that are there and the complications that are there. And that's where I want us to go. First of all, let's talk about diagnosis. She was, I would say, lucky to have caught it within one or so years. For so many other people, it takes long. Like for Njambi, she was from 13 years, 17 years later is when she actually got a diagnosis that what she has been going through from the time she was 13 years is called endometriosis. And it's a story of so many other women out there. Let's talk about the misdiagnosis issue in Kenya, that problem, and why probably it is a problem. What is it? What are the gaps? What are the loopholes that lead us there? And how do doctors diagnose, you know, endometriosis?
I think there's been a lot of challenge, truly, yes, and maybe some extent of misdiagnosis, because endometriosis is tricky. It mimics a lot of things. As we've seen with her case, someone would think, okay, this is a stomach issue. And also awareness at that point might not have been to the extent of where we think of women and we think of endometriosis together, African women, and we think of endometriosis together, because it was one of those things you would rarely just read behind in your books, because I do not expect to see this case. But as things started to show up, and I think that is when awareness over the last 10 years especially, there's been so much going on, so much research and so much even education or programs that have been established to just enlighten clinicians and obstetricians and gynecologists that yes, endometriosis is around. So now when someone approaches you as part of the Obstetrician and Gynecology Society, immediately endometriosis is there. But we don't want to stop there. We want to reach to all clinicians, to all healthcare work providers, to the community, because sometimes, as in her case, she went to a gastroenterologist, and it's right. Yes, obviously, if I have a stomach issue, I wouldn't blame her. She should go to a gastroenterologist. But maybe we reach a point where even those gastroenterologists or lung doctors or even just general practitioners, clinical officers, medical officers know of something called endometriosis, so that, yes, it's very difficult to diagnose. We'll talk about it soon. But we still keep it in our head, and we let the patient know, because, you know, sometimes they just come for answers. They just want to know what is going on with me. You know, sometimes when you give them those options, it gives them a lot of hope, and they'll say, I want to go and look for that. Who do I go to? And then they'll guide themselves to go to the right person. Who's the person who knows endometriosis most? That is the way we are heading. And that's what part of the Kenya Obstetric and Gynecology Society is trying to reach and to spread that awareness throughout. When it comes to diagnosing it, there's a lot of difficulty, as we said, because it can look like a lot of things. And unfortunately, there's no blood test that can tell you have endometriosis. There's no scan that can confirm for you. It will just tell you in a very advanced stage. Maybe sometimes you might see something that you'll be suspicious. But in some stages, you can't even, your ultrasound looks normal. You send her for an MRI or a CT, even her, she's lucky because the CT showed us something, which is still not endometriosis. It just showed something, and the doctor was smart enough to just go in. But what if it was like nothing was shown and she goes on to have that pain? So the only way to diagnose it is to actually look at it with your eyes. And the easiest way nowadays is laparoscopy, which is a small procedure where we do small holes, just like 2 to 3 holes in your abdomen, about just a pinpoint. And you go in with a camera, so it magnifies like a TV, everything for you. So you'll see those red small drops, sometimes even bigger, because if they stayed for a long time, for example. Or sometimes, remember the irritation we spoke about and things sticking together, you might see things stuck together. So also another challenge we had is laparoscopy, because let's talk about 2000 early. We just had few people who would do laparoscopy, maybe 1 or 2. So now more facilities, county hospitals have taken up laparoscopy. It has become accessible, covered by insurance even. So now it's become up to a point where if I see you're suffering with this chronic pain that is there all the time and you're not responding even to painkillers, so the next thing I do is I set you up for something called diagnostic laparoscopy, means seeing and looking inside to see if I can find that endometriosis, if I can cut it out and remove it. Sometimes it can be even as a treatment. Those, remember, sticking together as she has gone, they cut around, you cut around those to separate it, to return things to a bit of normality.
Right. So now that you've taken us to the treatment part, you've diagnosed. So what are the treatment options? And the question that many people usually ask, and when she was sharing her testimony, she said it recurred, and she had to undergo another. Is endometriosis 100% treatable? And what are the options? Let's also educate the masses about what is the next course of action when it comes to treatment out there?
I think with endometriosis, we wouldn't use the word treatable, maybe manageable.
Manageable.
Because she mentioned a very important thing. She mentioned estrogen, and we spoke about estrogen. Since the girl reaches her puberty, she'll have estrogen until menopause. Yeah. And remember, those abnormal cells that are placed in abnormal places, they love estrogen, they grow with it. So what do I do as a treatment plan? For example, if someone comes with just some little pain but still consistent, quality affected, we might start with some painkillers. That's now the least, maybe most mild management plan, where you just do like the Panadol, or some more and stronger bit medications that can be taken maybe monthly. We move on to the second stage, the estrogen she spoke about. I can stop that estrogen. I starve those endometriosis. So stopping that estrogen means sometimes that I make you menopausal. You're 20 years old, I give you medications, you feel like menopause. You can imagine how you feel, that bone pain. You'll just, it's not very, let's say you can't use it for a long time. Maybe, as she said, for 6 months maximum. Then we have other medications that we've started now to even use more, like for her, the other hormone we use. So remember, in pregnancy, that's also why she mentioned pregnancy. So estrogen, remember, it feeds that endometriosis and makes it grow. Opposite of estrogen is progesterone. That's another hormone. So when you're pregnant, you have a lot of progesterone. So it makes it shrink and become small. So the pain becomes less or even disappears. So now we've created ways of giving that progesterone when you're not pregnant. It runs in your body and it makes it shrink. And that it can be in the form of tablets, it can be in the form of an injection, an implant, some of us know, or the Mirena coil that she's talking about. Sometimes we even go to the point of surgery. As we said, surgery, we can cut off those endometriosis, remove it. It's like you're literally going into an abdomen and you're cutting off what you see are abnormal. You're cutting off the sticking tissues, you separate them. So those are some of the management options that are available.
What do you use to decide between hormonal therapy and surgery, or you just, how do you choose which one is best?
Depends on what the patient wants. What is her goal? How is the extent of her presentation? What has she used before? Maybe she's been using painkillers and it's not worked. Why would I put her on painkillers? Let's go up a step. Can we maybe use her insurance and really confirm that it's endometriosis? Okay, once I confirm, I still have to give hormones maybe to treat it. So basically that hormone part is becoming a really big aspect of managing endometriosis.
All right.
Yeah.
It's really a case-by-case thing.
Yeah, so it depends.
It's not like one-fits-all treatment. It's a case-by-case thing where you have to see like all sorts of factors to see, okay, now this is the best option for her. Yeah.
For somebody who's not worn that shoe, and they may not understand how this thing changes your life, personally, run us through how this changed your life. What could you do? What couldn't you do? Life now, like, how has this changed, just the trajectory of how Haveen has lived her life all through?
So initially, before diagnosis, the menses would be painful, and it would, especially the first 2 days, means you just sort of have to be in bed. That's it. You have to be in bed for the 2 days, and after that you can continue. closer to diagnosis is when I was having those extreme episodes. That is now taking 4 or 5 days out of my life where I have to be in bed. Yeah. So if I'm in uni, I can't do my classes, you know. If I'm working, I can't go to work, you know. And I missed a lot of work. Like, so I was already working by that time, but I missed like weeks, you know, because we didn't know what was going on. And because I was throwing up and I had spasms, it's so much pain here that it completely weakens your body, right? So even though you've had the painkiller and it stopped the episode, your body is worn out. So you're talking about a week. So if you have an episode, about a week. Then, you know, 3 or 4 weeks later, it happens again, another week. So you're not going to work. You're mentally exhausted because you don't know what the issue is. You're going for scans, you're going for, you know, you're going for all these things. You just can't see what the issue is. I went for an ultrasound and it did show there was some liquid, but they thought it was PID. Mm-hmm. You know, so you just don't know what's going on and you're just going through it. That's why when, you know, my doctor said, let's go in laparoscopically, I was like, please, let's do it, because we don't know. And after the first surgery, when I had the second one, you know, when it happened again, and that's when it actually took a bigger toll. Because now I'm wondering, how often is this going to happen? Am I going to have to do this every 5 years? Is it going to reduce from 5 to 4 to 1? I don't know. Just like the episodes were, you know, monthly, weekly, you know. So I didn't know, and that's when I really went in a slump mentally, because you just don't know. And you know, honestly, even the doctors can't tell you. Mm-hmm. They can't tell you.
I think you live in a dread because you're worried of the next pain. Yeah. You're worried of the next period. Yeah. So even when you get the time around your pain, you're suffering. Yeah. When you're relieved a bit, you're worried of the next pain. So you're already making plans of how to live.
And my doctors were like, you know, they were so good. And they said, we don't want you to suffer like this. I don't want you to live wondering when is the next one going to happen. I want you to live a normal and happy life. You can manage it and we can manage it well, but we don't want you to be sitting like this and thinking, because it takes a really big toll. Yeah. And that's why even the support group helped so much, because like you said, as a person who hasn't gone through it, you don't know what to tell me. Yeah. Someone who has gone through it, we may have advice that will help me, you know, and that's really important.
Yeah, the one thing I want to come out very clearly is that we may say it's not treatable like 100%. There's no like a direct treatment for endometriosis, but what is out there is that the symptoms can be managed, and your quality of life can actually improve. You do not have to suffer in silence, in pain, in whatever it is that you're going through as a woman. There are options out there that can improve the quality of your life and bring you almost to near normal, if not normal, you know, because there are people who are out here saying that they've gone through procedures that have helped them. Let's talk about something that has also been like a very sensitive subject. From the symptoms, there is it can delay, you know, or even make it a bit tricky for a woman to get a child. Even in the options of treatment, when you're mentioning pseudomenopausal and pseudo-pregnancy, you know, hormonal therapy, the concern would be there, you know, can one have children with endometriosis? And has it happened, you know, just to clear the air around that particular sensitive subject? So
we don't say endometriosis equals infertility, but we do say about almost 40%, 30 to 40 of people who are living with endometriosis might have some difficulty in conceiving. Yeah. Remember, these people are also having difficulty having sex because of pain. That alone can stop you from actually conceiving. And then remember the sticking together, and the ovary now having endometriosis. Ovary is where the eggs are from for you to get pregnant. So those are things that can play a role. But as we said, it's a case-on-case basis. And usually if someone knows endometriosis, we give them options. So we align the fertility with our management plan. So for example, if someone has a Mirena, maybe they want to get pregnant, we remove the Mirena and see if they can get pregnant, or now assist them with getting pregnant by other methods like IVF, for example, or where you artificially try to get someone pregnant. So it's just based on base cases. As we said,
but it is possible.
It is possible, yes. It is possible, definitely.
Right. What is the cost implication of treatment?
I don't think I would say cost implication of treatment, but let's start with cost implication of diagnosing. Because how many times have you gone to a doctor before you were told endometriosis?
Exactly.
So that alone, you're doing a scan. You're being told you have a urine test, a urine infection. You're doing a urine test several times. You're doing a stool test several times. You're doing a chest X-ray. But once you're diagnosed, I think the treatment now, as we said, the laparoscopy part, for example, if you want to do it laparoscopically, we have now insurances. They've also become aware, and it's being covered by insurances. Even SHA program covers it. When it comes to the other aspect of management, medication-wise, we have also some of the health sectors that are providing us, for example, with the family planning methods, out of free of charge. So it's still, treatment is what we need. We need to reach a point where we get treatment quickly. You get me? We get to the management part quickly. So we skip that long 10 years of waiting of diagnosis, which is more of a burden than the actual management. Yeah.
Was that an issue for you? Did it take a toll on you and your family financially?
Definitely.
Yeah?
Definitely.
Yeah?
I mean, I did have
especially
insurance,
the surgeries.
but at that point, remember, this is 2014 when people were not really talking about it so much. So, yes, the insurance did cover a percentage, and a percentage had to be paid out of pocket, you know, which I'm lucky for me that my father could do it. You know, other people might not have the same privilege. And like she's talking about, even pre-diagnosis, the number of times you're going to the hospital to get scans, in my case, to get pethidine because I needed it, it adds up. It adds up, and a lot of that stuff may not even be covered. So I'm glad to hear that insurances are now doing that, and SHA is also doing that, because it's really important, because now you're stressed physically, mentally, and financially. You know, so how is that going to help you have a normal life? It's not. So it's really, it does take a big toll on you, especially pre-diagnosis.
All right. Let's talk about the lifestyle changes that, you know, can help, you know, in management of endometriosis. Just to look at what women can do. Probably you can start with you having to tell us, you know, what is it that you have embraced that you are not doing before that has helped you, or what have you learned?
Lifestyle-wise, like, you just have to also be, I was not a very, you know, I'm a very sedentary person. You know, I took up things like yoga, because yoga also helps your mind. So yoga, changes in diet, which I had to make more forcibly rather than out of necessity, is, you know, white flour is a very big, how do we say it? For estrogen. For estrogen, it produces estrogen, so it's a big trigger. So wheat, white flour, those types of things really do trigger the estrogen, which then triggers the endo. So I had to reduce my consumption of that. Lifestyle-wise, I wouldn't say, like I said, the surgeries have helped me quite a bit, so I don't have that pain anymore. I didn't need to miss work because of my periods. It's just also a lot of your mindset that you need to. What I went through was one of the worst things that I've gone through in my life. However, when I join a support group and I see other ladies suffering so much more than I have, I'm grateful. And then I figure out, how do I help? And helping them has helped me as well.
All right.
Yeah.
Let's talk about that support group.
Yeah.
What motivated you to join one? You had already gone through surgery. You were on your path to feeling better.
Yeah.
One would imagine just live your life and move on. But then for you, why was it pivotal to really be part of that family of sisters? Yeah. And how has it helped you?
Okay, so post the first surgery, like I said, I thought everything is okay. So I wasn't really, that's not when I joined. I joined it in 2019 after the second one. So why I joined it is because my gynecologist said, you are not looking okay. Because I was crying in the consultation room. And he said, you're not okay. I'm going to refer you to this support group. You know, here is a number, call them, join. Because they're going to help you, and they really did, you know. So I joined Endo Sisters, which is headed by Doris Murimi. It's called Endo Sisters East Africa Foundation. And through joining that group, it's a WhatsApp group. It's a group where you talk about your problems. You know, someone is suffering this. Chances are, you know, someone else has gone through it and will give you some sort of thing to relieve you, or, you know, something you can do for yourself. And we're about 100 members, and that's how we learn. And somebody learns something new. I've seen a new article, there's a new treatment, is there anyone on this? You share it with each other and you help each other. Okay, I need a diagnosis, but I don't know, I'm in Mombasa, who can I go to? Someone will know where to send you. Yeah, so that really helped me. And then when I realized that, you know what, actually, I'm quite lucky with how my journey was. I need to help people.
Other people.
And I became more active in the group. And then they made me a board member. So my work now, my main work as a board member is education and awareness. Get it out, like she said, it's not only to gynecologists, it's to all clinicians. That's because they can present anywhere. So we get the information out, we get it out to clinicians, you get it out to schools, so that you can get early diagnosis, and you get it out to people who would be the support of the people who are going through endometriosis. So even they can understand what this lady or girl is going through and how I can help her. So education and awareness is one of the biggest things that we are working on.
All right. Dr. just coming back to you, what would you say, as we mark this month of awareness, what would you term as the biggest challenges in managing endometriosis in the context of our country? You can choose to go whichever direction, from even lack of awareness, which I think we've really done something about. We're not there yet, but what are the biggest challenges, and how do you propose we address them?
I think the biggest challenge now we have is, let's look at both, as we said, the patient themselves and the clinicians themselves. Normalizing period pain, normalizing struggle and suffering should be out of the picture. We are at a period of women empowerment. If you have something that is really affecting the quality of that life, which we are supposed to empower, I think that should be something that is a priority. So we, at the community level, we at schools even, we shouldn't normalize a lady to have to go through that alone. And at the clinician aspect, we are still spreading the word. We've reached a very good step with our society as obstetrician and gynecologist, but we still have a mile to go in extending that information and availability of maybe those procedures that can be done to maybe increase the capturing of people who are getting.
So in terms of training and
training, yes, empowering, equipping especially, and maybe even training more people to train others, so that it becomes like a pyramid. So more exposure, more numbers covered. We reach a point where it's like tuberculosis or even HIV. It should be at that stage, or hypertension or diabetes, because it's something that is if not more painful, and it goes on with you through your life. It affects every aspect of your life, just like the others, for example. So yes, there's still more to go. We are much better than when we were in 2015, 10 years ago. And we really hope over the next few years, we really normalize talks, we normalize management, and even saying, I have endometriosis. Yeah.
I think that will go a long way, especially concern now. The biggest challenge is the shortage or the lack of enough endometriosis experts in the country. It's only a few who know about it and they know when to catch it and what to do about it. So spreading that information to the communities where women are actually suffering in silence will go a long way. And also post care after treatment, the follow-ups, the support systems that she's talking about, just sort of working together as one family and helping others to know that it's actually possible to live a normal life, as you try to manage endometriosis.
So it's multidisciplinary. Yes. You have your psychologist or support group. You have your family that are also involved. You have the community. You have your doctors, your nurse, your occupational therapist. It's, yes, as you said.
As we wind up, maybe 30 seconds each, I'm really pressed for time for your clarion call. Let me start with you, the wearer of the shoe, who knows where it pinches. Tell us, what would you advise a woman out there who's watching and they are, going through this, and what would be your clarion call as we close this program?
The slogan at Endo Sisters is be informed and take action. So be informed that there's something like this that exists. If I know it, I know I will tell my friends, I will tell my cousins, I will tell. If you know about it, tell other people so that they can correlate and see, are these my symptoms? Maybe now I need to see a gynecologist. Information is the key thing here. And that is what will lead to early diagnosis. That is what will lead to better prognosis after surgery and treatments, and is what will lead to a more normalized life where people realize, like she said, don't normalize period pain. So information is key. That would be my last.
You're taking parting shot. And you're reading a lot about endometriosis.
Yeah.
She's become a doctor of endometriosis.
Yeah, and in fact, I would like to also mention that EndoSisters, we do have resources, books that are written by our CEO called When Something Is Wrong and Demystifying Endometriosis. So you can go on our website and find those, and they really give you key information that will help you.
All right. Daktari, let's close this.
Yeah, for women, I would say if you are suspicious of your period's pain not being to that extent where it's really now you want it looked up, you can go to any obstetrician and gynecologist. We have ensured it's part of our teaching and ongoing training that has been going on. So yes, you get the right to be investigated for endometriosis, and even going to clinicians or other medical officers who are even there. Speak out. What do you think? Are you suspicious of endometriosis? Say it, and then we clarify for you. So, and spread the word. Talk to your sisters, talk to your relatives, neighbors, the young girls that you see that are struggling. Give them those opinions and options that are there. Thank you.
Thank you so much. And that's how we wrap it up this particular morning on health and lifestyle. I was engaging this morning Dr. Hiba Ahmed. She's from the Kenya Obstetrical and Gynecological Society. And of course, I was having just sinking deep into the life and experience of Haveen Bansal. She's an endometriosis warrior, as they were just helping us create more awareness around this particular condition. And as we wind up, do not normalize period pain. I mean, it's not normal. It shouldn't hurt. It shouldn't be painful. And there are things that can be done to be able to make you live your life fully and experience your potential as a woman. Please go out there. Please speak out. Please reach out to your sisters. And that's what we are saying this particular morning. Thank you so much for watching Health and Lifestyle. My name is Safin Achieng Oma. Have a lovely day ahead.